This is Dr. Stephen Pipe. I'm a pediatric hematologist and a professor of pediatrics and pathology at the University of Michigan. And I'm presenting today on a history of hemophilia treatment, from non-replacement therapy to gene therapy. Learning objectives for today are to outline the current and emerging approaches for treating hemophilia, including non-replacement therapies and gene therapy. This slide is depicting the correlation between underlying hemophilia severity, depending on the patient's underlying endogenous factor VIII levels, and their risk for joint bleeds. And what this slide is showing is that it's the patients who have a true severe hemophilia with a factor VIII activity less than 1% who experience the most joint bleeding. However, even having a minimal amount of factor VIII of as little as 1 to even 3% residual factor VIII significantly moderates disease, and we see a reduction in the annualized number of joint bleeds. And if patients have endogenous levels that are above 5%, joint bleeds become quite unusual. And there's probably a level around 12 to 15% where the risk of joint bleed is almost completely abrogated. And this observation of joint bleeding correlation with patients' endogenous levels was actually what drove the idea of prophylaxis, whereby regular protein replacement therapy would maintain factor levels above these critical thresholds to hopefully moderate the patient's underlying disease. On this slide, though, we see the challenge with traditional clotting factor replacement therapy. Right after the infusion, the patient achieves a peak level within a few minutes after infusion. But with each tick of the clock after that infusion, the factor level is declining based on the pharmacokinetics of the protein replacement, whether that's factor VIII or factor IX. If we are looking at a typical prophylactic regimen of dosing every other day, patients will still spend a considerable amount of time, particularly in the hours leading up to the next dose, when they are below a critical level and continuing to be at risk for breakthrough bleeding. The bottom half of the graph is depicting the impact of a factor product that has an extended half-life pharmacokinetic property. And again, even though this does modulate the pharmacokinetic profile for the factor, depending on when the patient takes their next dose, they can still spend a considerable amount of time below critical thresholds and remain at risk for breakthrough bleeding. If we look at factor VIII prophylactic therapies, this is a summary of the results of prospective data collected as part of phase III studies for a number of both standard half-life factor VIII products as well as extended half-life factor VIII products. And if we look at the range of annualized bleed rates for the standard half-life factor VIIIs, these range between 1.6 to as high as 6.5 annualized bleed rates. And if we look at the percent of participants who were able to achieve 0 bleeds during the observation period, those range between just over 25% to up to just over 60%. With the extended half-life studies, again, we're seeing annualized bleed rates with a range between 2.9 to 4.7, and the percent of participants achieving 0 bleeds range between 38 to 45%. Well, what's the implications of patients continuing to bleed, even sporadically, on a prescribed prophylactic therapy? This is data presented from the HTC in Bonn, Germany, in which Dr. Oldenburg has presented a schematization of the long-term outcome results that he's observed in his clinic over the past 25 to 30 years. Across the bottom is the advancing decades in the patient cohorts, and on the left side of the graph, in the vertical axis, is joint score. And the joint scores that we're going to be looking at include clinical scoring methodology and a radiologic scoring methodology. The lower the joint score indicates less evidence of joint damage. The yellow box is depicting the early childhood experience in patients who were placed on primary prophylaxis early on. And what he's presenting here is that below a arbitrary joint score of 2 as being a marker for clinically significant joint damage, there really isn't evidence of much deterioration in the joint status of these young boys. And if we rely on the clinical scoring tools alone, well out into the second and third decades, it can be challenging to identify any evidence for joint disease in these patients. However, if you use a more sensitive radiologic scoring tool, now he's able to demonstrate evidence of joint damage in these joints. Now keep in mind, this is a population of patients who have been using primary prophylaxis over the entire duration of this data collection. And this suggests with the current level of prophylaxis that patients are receiving, we are still seeing risk for progression of joint disease. What I'm depicting here are some of the eras that we've come through in the treatment of hemophilia. The pre-replacement therapy takes us all the way up to about the late 1960s, when really we had no available therapies for patients. The replacement therapy era really began with the availability of plasma-derived factor products, and then eventually the recombinant products that became available in the 1990s. When products were difficult to obtain, patients tended to treat on demand. This did have an impact on clinical outcomes for patients because they could treat in the home setting and get on top of bleeding quite quickly. Prophylaxis, however, offered the opportunity to prevent joint bleeding, hopefully completely. Initially, this was conducted with the standard half-life agents, but with recombinant platform, bioengineering allowed for modified recombinant clotting factors that could extend their half-life properties. What we've just started into is the non-replacement therapy era. Here we're no longer relying on protein replacement, but a couple of different strategies that don't involve replacement of either factor VIII or factor IX. Substitution therapy refers to mimetics that substitute for the clotting factor activity of factor VIII. And there are a number of other agents which are targeting the natural anticoagulants of hemostasis, attempting to rebalance the hemostatic system. And there's a number of different strategies that are part of the non-replacement therapy era. Bispecific antibodies are what are functioning as substitution therapy, but small interfering RNA molecules that are capable of knocking down natural anticoagulants, monoclonal antibody inhibitors that can target the natural anticoagulants, and even bioengineered serpins can have an effect at rebalancing the hemostatic pathway. And all of these are at different stages of clinical development. We are on the verge of potential gene therapy. This would be definitive protein replacement, but not coming from IV infusions, but rather through endogenous production by providing either a good copy of the gene through gene addition or possibly gene editing and even cellular therapy techniques. What this slide is depicting are the different properties of factor delivery or non-factor delivery or gene therapy that we've just discussed. So across the bottom are the factor levels that are achieved when patients are on regular prophylaxis. You can see the typical peaks and troughs that we presented earlier on in this presentation. With the extended half-life products, these change the pharmacokinetic properties, and in some cases, they can allow us to raise the trough levels that patients are maintaining during those prophylactic regimens. With the non-factor therapies, however, there's no measurable factor that's obtained because we are not replacing with the protein, yet we are still maintaining a hemostatic benefit at a steady state level with that delivery. And then finally, with gene therapy, we get a merger of both of these techniques where we are achieving a steady state factor delivery for the patient, and this has a steady state hemostatic effect as well. Another way to help us understand some of the non-replacement therapies is to use this analogy of a balance. Now, in the normal hemostatic balance, one side we have the procoagulants, which are trying to drive coagulation forward, and then we have the natural anticoagulants, which are counterbalancing that. And at steady state, we're at a normal hemostatic balance without too much clotting and without too much bleeding. However, with loss of some of the procoagulants, such as would be found with a factor deficiency, the natural anticoagulants are still present in full force, and so we see a shift of the weight of this balance towards more bleeding, and this is the phenotype that we would see, for instance, in hemophilia. So what we've been doing for the last several decades is to replace the procoagulants that's missing in order to restore hemostasis. So in the context of hemophilia A or B, we can replace the proteins factor VIII or factor IX. However, if you can't use those replacement therapies, for instance, if the patient has developed an inhibitor, we have to rely on bypassing agents. These include the activated prothrombin complex concentrates and recombinant factor VIIa. What we've introduced recently into the clinic is a substitution therapy, which is emicizumab, which also acts as a substitutive therapy to improve hemostasis by driving coagulation. This slide is depicting the mechanism of action of emicizumab. So on the left, we see the natural state where factor IXA, as the protease, is in close proximity to factor X on the phospholipid surface. And what allows them to come into contact with each other as part of the assembly of this complex is the availability of the cofactor, which is factor VIIIa. Factor VIIIa, in some respects, acts as a scaffold to help bring factor IXA in the right orientation and proximity to the factor X molecule so that the enzymatic reaction can move forward at a very high rate. What's being accomplished with the bispecific antibody substitution is this bispecific antibody has one arm of the antibody that has an affinity for factor IXA and the other arm which has an affinity for factor X. And so in the presence of that bispecific antibody, it again can bring factor IXA and factor X in close enough proximity to ensure that the clotting reaction can move forward more efficiently. Emicizumab is a humanized bispecific monoclonal antibody that bridges the activated factor IX, factor IXA, and factor X to restore the function of the missing factor VIIIa molecule. Now, it has no structural homology to factor VIII, so it's not expected to induce factor VIII inhibitors or be affected by the presence of factor VIII inhibitors. But it has the advantage of having a very long half-life because it's an antibody. It can last up to approximately 30 days. And it can also be administered subcutaneously because it has a very high bioavailability. And this drug now has been approved in several countries for once weekly, every 2-week, or every 4-week prophylaxis in persons with hemophilia A with and without inhibitors of all ages. This table is giving the high-level data from the clinical trial programs, which was the VIII clinical trial programs of emicizumab. This was initially tested in adolescents and men with factor VIII inhibitors. This was the VIII trial. And the top-level data here is patients who were placed on prophylaxis with emicizumab had an 87% reduction in bleeds compared to those who were on no prophylaxis. And if we look at the percentage of patients who achieved 0 bleeds during the observation period, 63% who were on weekly prophylaxis with emicizumab achieved 0 bleeds, compared to only 6% of those who were on no prophylactic therapy. And if we look at the treated bleeds with emicizumab prophylaxis compared to a group of patients who were on prior prophylaxis with bypassing agents in a non-interventional study, those patients who are on emicizumab weekly still demonstrated a 79% reduction compared to those who are on bypassing agent prophylaxis. This is what the VIII clinical trial design looked like. Patients came into the study either on episodic use of bypassing agents or on bypassing agent prophylaxis. If they were on episodic therapy, there was a 2-to-1 randomization to either emicizumab weekly or continuing with no prophylactic therapy. For those who came into the trial on prophylaxis, they went directly onto emicizumab, but there was a group of patients who were on prophylactic treatment with bypassing agents who were part of the non-interventional study. And so this allowed for comparison when those patients came into the study and were placed on emicizumab, and this was the D arm of this study. All of the patients were initiated with a loading dose of 3 milligrams per kilogram weekly for 4 weeks, and then followed by the maintenance dosing of 1.5 milligrams per kilogram weekly. This slide shows the outcome across these study groups. The Group A patients who were placed on emicizumab prophylaxis, we see their bleeding events in blue, bleeding events treated with bypassing agents in yellow, treated events for spontaneous bleeding in red, and treated events for joint bleeding in orange. And you compare that to the Group B, who did not receive emicizumab prophylaxis, and you can see the marked improvement for the emicizumab prophylaxis group. The Group C patients include those who came into the trial already on bypassing agent prophylaxis, and they continued to maintain good bleed control, similar to those who had switched from on-demand treatment with bypassing agents onto emicizumab prophylaxis. This slide showing the improvements that were observed using a health-related outcome measure, the HemoQual. And there was significant improvement in the patients who were maintained on emicizumab prophylaxis, and this was particularly noted in overall physical health as well as in a number of other parameters that are detailed in the table on the right. With the success of the observations from the HAVEN-1 trial, the HAVEN-2 trial built on this by studying emicizumab prophylaxis in pediatric patients who were under 12 years of age. Here, the annualized bleed rates across the patients on prophylaxis was close to 0. Now, there was no comparator in this trial because all the patients were placed onto prophylactic therapy. But if we look at the percentage of patients who achieved 0 bleeds, it was 87% on the weekly prophylaxis. And since there were some individuals who came into the trial who had been on prior bypassing agent prophylaxis, this allowed for a comparison. And there was still a 99% reduction in treated bleeds for the emicizumab treatment group. Moving on to the HAVEN-3 studies, this is now looking at the effect of emicizumab in adolescents and men who did not have factor VIII inhibitors. So this slide shows you the design of this trial. So patients could come into the trial on episodic therapy or on prophylactic factor VIII replacement. For those that came into the trial on episodic therapy, it was a 2-to-1 randomization to either emicizumab weekly, emicizumab every 2 weeks, or continuing with no prophylaxis. Those who came into the trial on prophylactic therapy, they switched to emicizumab on a weekly maintenance regimen. The top-line data shows that the annualized bleed rate was still quite low, with a median of 1.5 and 1.3 on Q-weekly dosing or every 2-week dosing, respectively. Compared to individuals who were not on prophylaxis previously with factor VIII prophylactic regimen, there was a 96% and 97% reduction in treated bleeds on the weekly and every 2-week prophylactic regimens. And if we look at the percentage of patients who achieve 0 treated bleeds, 56% and 60% on weekly and every 2-week respectively, compared to 0 for the group that were not on prophylaxis. For those individuals who came into the trial with a prior history of factor VIII prophylaxis, there was still a 68% reduction with switching to emicizumab prophylaxis weekly. From a safety perspective, the most common adverse reactions were injection site reactions, headache, and arthralgia. There was some significant thrombotic complications, both thromboembolism as well as thrombotic microangiopathy. This was only observed in the HAVEN-1 study. The thrombotic microangiopathy was reported in 0.8% of the patients, and 8% of the patients who received at least one dose of the activated prothrombin complex concentrates. And thrombotic events were reported in 0.5% of the patients and in 5.4% of the patients who received at least one dose of activated prothrombin complex concentrates. With a deeper dive into these patients, it was clear that the patients who had these thrombotic complications were all using activated prothrombin complex concentrates for greater than 24 hours at doses that were above 100 units per kilo per day. So based on this observation, a risk mitigation strategy was imposed for all of the other HAVEN studies to either avoid the use of activated prothrombin complex concentrates or strive to use dosing and duration that was below these risk thresholds. And since that risk mitigation policy has been instituted, there have been no further events in patients who've adhered to that. And this became incorporated into the label to ensure that patients take note of this possible interaction. Returning to our balance analogy, here again, we're presenting the hemophilic state where there's been a reduction of procoagulants, but the presence of the full force of the natural anticoagulants is contributing to the overall bleeding. So the other possibility we have to intervene here, instead of adding procoagulants, we could somehow either remove or inhibit the anticoagulants on the other side of the balance and therefore restore hemostasis. So this slide is depicting a typical view of the coagulation system driven from the extrinsic pathway through to the generation of thrombin and ultimately to fibrin formation, with the amplification loop through the intrinsic pathway to amplify thrombin generation. Each component of this pathway has a natural anticoagulant which is regulating hemostasis. Tissue factor pathway dampens down the extrinsic pathway. Antithrombin dampens down factor Xa and thrombin within the common pathway, and activated protein C acts to dampen down the intrinsic pathway by targeting the cofactors activated factor VIII and activated factor V. And what we've explored so far is that emicizumab can function as a substitution for factor VIIIa. But of the other strategies for hemostatic rebalancing, there are now clinical trial programs that are examining ways targeting each of these natural anticoagulant pathways. Fitusiran, we mentioned, is a small interfering RNA that acts to knock down antithrombin levels in an attempt to restore normal hemostasis. There are monoclonal antibodies that have been developed that can target tissue factor pathway inhibitor. And there is a serine protease that's been bioengineered to target activated protein C. This now brings us to gene therapy as the next era that we are potentially entering into. So the concept here is that instead of the challenges of protein replacement with the pharmacokinetic challenges we've talked about, here, instead of delivering protein on a regular basis, we're going to do a definitive replacement of the therapeutic transgene into a target organ, in this case the liver. This transgene has to be packaged in some sort of a delivery vehicle. To date, these have been viral vectors, which can package that therapeutic transgene. This can then be injected into the patient, and these viral vectors can home to the target organ like the liver. They're taken up by the individual hepatocytes. The uncoating of the vector allows the transgene to have access to the nucleus, and there the transgene remains where it can access the normal machinery of the cell. The cell begins to synthesize either factor VIII or factor IX to restore hemostasis. There is also the possibility that ex vivo cellular therapies could also be used as a way to treat hemophilia, and these are also being explored in some innovative clinical trial settings. So if we think about these new paradigms of substitution and hemostatic rebalancing therapies, how do they compare to the investigational gene therapy that is currently underway as well? Well, if we look at the pros that the substitution and hemostatic rebalancing therapies offer, these are sub-Q delivery. They have a very low burden of administration for the patient. They allow patients to achieve a steady state hemostasis. They have both pediatric and adult applications, and they seem to have good efficacy in both inhibitor and non-inhibitor patients. There are some cons. It's likely that these therapies are not achieving normal hemostasis, but possibly still curative with respect to the phenotype of risk for repeated joint bleeds. We've mentioned that some of these can carry thrombotic risk, and there often are risk mitigation strategies that have to be used for the safe use of these products. We didn't have time to talk about this today, but these novel therapies introduce problems with how we assay the hemostatic effect. These patients may still have breakthrough bleeding events, and so these patients still have to have access to traditional therapies to treat breakthrough bleeding. And because of the regular need for prophylaxis with these therapies, there is still an annualized expense to the patient. If we look at investigational gene therapies, some of the advantages is the possibility of a one-and-done treatment. Instead of regular prophylactic therapy, once there is definitive transduction of the liver cell, we would expect that patients would continue to express that therapeutic protein for years and years. This should achieve a steady state hemostasis, and it's possible that not only would we be able to achieve curative levels with gene therapy, but we may even be able to maintain patients in the normal range. And because of the one-and-done treatment, this is now the first therapy that offers the opportunity for annual cost savings. Now, there are plenty of potential cons that are being looked at in the clinical trials for gene therapy. There are some challenges with eligibility. We don't yet have therapies that we can offer for pediatric patients or for those with inhibitors. And a significant number of patients are not eligible for these therapies because of pre-existing immunity to the viral vectors. There are lots of known and unknown risks with this therapy. There are immunologic challenges. There are issues that may relate to cellular stress from overexpression of these proteins in the cell. And there's some unknown risk related to potential integration events and genotoxicity. We're not certain of the durability for these therapies or for the ability to redose patients if they lose their expression over a long period of time. And almost certainly these therapies are likely to have high initial costs, even if they lead to annualized cost savings for the years afterwards.